can go ahead and start.
Okay, great. So this is my presentation for the research that I have in progress so far during fellowship. So my big project is a trial of a combination of fulvestrant, alpelisib, and venetoclax in hormone receptor positive, HER2 negative, PIK3CA mutated metastatic breast cancer. So the vast majority of breast cancers are hormone receptor positive, meaning that the estrogen receptor is the major driver in these cancers. And hormone therapy has repeatedly been shown to be highly effective in the treatment of both PR positive and PR positive breast cancer, and thus it's a mainstay of treatment. Several options for hormone therapy exist, including tamoxifen, a selective estrogen receptor modulator, aromatase inhibitors, and fulvestrant, a selective estrogen receptor degrader. But the efficacy of hormone therapy is limited by resistance, which can either be de novo or resistance that's acquired during treatment. And there are several ways in which breast cancers can develop resistance, but one that I'll highlight is that some breast cancers can become more dependent on the PI3 kinase pathway than on the estrogen pathway for growth. So here is the PI3 kinase pathway, which is a key component of cellular growth, differentiation, and proliferation. When activated, PI3 kinase facilitates the PDK1 phosphorylation and activation of AKT, and AKT is a serine threonine kinase that has 3 isoforms, and when activated, phosphorylates and activates intracellular proteins that affect cell growth, cell proliferation, and cell survival, including mTOR and many of our popular oncologic targets here. Now, mutations in this pathway are very common in many different malignancies. The one that I've circled here is the PIK3CA mutation, which is the most common somatic mutation in hormone receptor positive breast cancer. It's a mutation in the catalytic subunit of PI3 kinase alpha. Given the prevalence of the PIK3CA mutation and the pathway of hormone therapy resistance, multiple PI3 kinase inhibitors have been evaluated in this setting. The most successful of these is alpelisib, and the phase 3 trial SOLAR-1 was published in the New England Journal in May 2019. And this looked at the combination of fulvestrant and alpelisib in hormone receptor positive advanced breast cancer. Now, specifically in the PIK3CA mutated cohort, the combination resulted in an improvement of the progression median PFS to 11 months from 5.7 months in fulvestrant plus placebo. So based on this trial, the FDA approved alpelisib for use in this patient population. And just to highlight, alpelisib is actually a PI3 kinase with high selectivity against the PIK3CA mutant isoform of the PI3 kinase, which is likely why it was the most successful of these. Now, both in SOLAR-1 and in practice, we see that not all patients with PIK3CA mutations will respond to anti-estrogen plus alpelisib. And in SOLAR-1, in the PIK3CA mutated cohort, the overall response was actually 26.6%. So Dr. Parsons' lab actually looked at this issue, and they used a PIK3CA knock-in mouse and exogenous administration of estrogen to model this specific type of breast cancer. And when these mouse cell lines were treated with alpelisib, the expectation was that they would become more sensitive to fulvestrant. However, this wasn't the case. When the cell lines were examined, it was found that the combination failed to induce cell death, though there was a significant increase in the pro-apoptotic BCL2 family member BIM. So members of the BCL2 family of proteins are intracellular regulators of apoptosis, and their expression is commonly modified in tumor cells in order to promote cellular survival, and they've thus emerged as popular targets in the treatment of cancer. And the BCL2 structure consists of four BCL2 homology domains. These are BH domains, and they can be bound by either pro-apoptotic or anti-apoptotic molecules. There are three main subgroups, one of which is the BH3 only pro-apoptotic protein. And these BH3 proteins, which include BIM and BAD, as well as others, contain only the BH3 domain. And they act as activators of multi-domain pro-apoptotic proteins, including BAX and BAC, or they can be inhibitors of anti-apoptotic proteins, all leading to increased mitochondrial permeability and activation of the mitochondrial pathway of apoptosis. So given what Dr. Parsons' lab saw about the upregulation of BIM with fulvestrant and alpelisib, as well as the fact that BIM can be neutralized, or BIM can be bound and presumably neutralized by anti-apoptotic BCL2 family members, the hypothesis was, or the question was, can BH3 mimetics be used to allow the upregulated BIM to mediate apoptosis? So mouse and human cells were then treated with fulvestrant, alpelisib, and a BH3 mimetic, specifically navitoclax. And the triplet combination was noted to be highly effective in inducing cell death. And the efficacy of this triplet is the rationale behind our trial, though we're going to be using venetoclax, given that it causes less thrombocytopenia and is better tolerated. So while the triplet combination hasn't been used before, there has been a trial that has evaluated the use of venetoclax in the treatment of breast cancer. Specifically, this phase 1b dose escalation trial that was done in Australia, looking at patients with metastatic hormone receptor positive and BCL2 positive breast cancer. And in this trial, the maximum tolerated dose was not reached, and the combination was very well tolerated, and the clinical benefit rate was 70%. So that inspires confidence that we'll be able to add this to the already approved regimen of fulvestrant and alpelisib with success. So our trial is going to be the first time that the triplet combination is being used. So we're going to have a 6-patient run-in, safety run-in, followed by a larger pilot study that we're very hopeful is then going to lead to a larger phase 2 trial of the combination. So I just want to briefly talk about another trial that we're just starting to, and we means me and Dr. Tiersten, but that we're just starting to work on. But I'm excited about it and just wanted to mention it a little bit. And this involves the use of artificial intelligence, virtual reality, as a treatment for hot flashes in breast cancer patients. So hot flashes are a very significant problem for our patient population, and they can occur in up to 70% of patients being treated with anti-estrogen therapy. And they have a significant effect on our patients' daily life. They cause discomfort, distress, social embarrassment, insomnia, fatigue, and they're a very frequent reason for discontinuation of treatment. And we do have medications that can help treat hot flashes, but a lot of patients are very hesitant to add a medication to treat an adverse effect from a medication. So this system is called the Luna Artificial Intelligence Virtual Reality Coaching System. And it's from a company called XR Health. And it's a coaching system in a winter wonderland setting that offers cognitive behavioral therapy, as well as mindfulness-based stress reduction protocols. So these are some images from the system. A flashing snowflake leads you through the program. And this is just an image of what you might see if you're using the program. So the system has already been used in a pilot trial with impressive results. There were 37 patients who were included, all of whom had hot flashes, and patients were encouraged to use the virtual reality system either daily or twice daily for a 24-day trial period. They didn't need to use the system exactly when they were having hot flashes, just daily during the period. And study surveys were conducted both before and after the intervention to assess the subjective intensity, frequency, and the life disruption from hot flashes. And following the intervention period, the frequency of hot flashes was reduced by 50%. So this was a non-controlled and non-blinded study. So now we're actually taking the next steps to do a randomized controlled trial at Dubin. And we're very excited about that. So in summary, these are the two trials that I'm working on the most right now. And I think that they're going to be, once we get them to the next phases, hopefully very exciting. And I'm happy to take any questions, I think, through chat or wherever. Thank you.
What's the control for your hot flash VR?
So they have the system has a control that would be just a virtual reality program without the coaching, without the Winter Wonderland.
And is the idea that showing cold environments would somehow make people feel fewer hot flashes? I didn't understand the.
Yeah, so it's a coaching system within the Winter Wonderland. So and it's a cognitive behavioral therapy program, so that once the patient has done the program, then they can use the tools that they learn there, and I guess transport back to there if they're having a hot flash.
Got it. Okay. And the toxicity of alpelisib and venetoclax, there's no overlapping toxicities. You don't have to do a larger phase 1.
There really aren't any overlapping toxicities. It's, alpelisib, we see a lot of hyperglycemia. Venetoclax in the breast cancer patient population, there was some thrombocytopenia, but the issues that are seen with venetoclax in liquid tumors really weren't seen in the breast cancer patient population.
Okay, thank you.
Danielle, thank you. That was an excellent presentation. The PIK3 mutation, is that preserved in primary tumors as well as sites of metastases, or is there some PIK3 discordance?
I'm actually not sure.
Okay. No, I think it would be interesting also to see if potentially liquid biopsies can see if again there is not fidelity from primary to sites of metastases, whether it's something that can evolve and be monitored through liquid biopsies at some point. I don't know if PIK3 is particularly shed in cell-free DNA. And then regarding the second trial, is this a proprietary headset that patients will wear?
Yes,
And
so from the company would give us the goggle system.
yeah, because I just wonder, that's highly designed, and I just wonder if potentially through other devices can effectively share similar content, so that maybe if this does prove to be effective, patients can have access to it. Obviously, there are proprietary issues here, and
yeah, they have an app that I think the goggles work in conjunction with the app that the patient downloads, but I think right now it also just has to be used with the goggles because of the virtual reality component of it.
Got it. Thank you.
Okay, well, thank you. Janie?
Yeah, I'm here. Let me share my screen. Good morning. Okay, is everyone able to see the screen?
Yes.
Okay, wonderful. So I'm Janie, I'm a second-year fellow like Danielle, and I'll be giving my research in progress presentation as well today. Just a brief overview, I'll be talking about 2 studies in progress as well. One is a dementia biomarker study in prostate cancer patients, and the other one is a rapid sequencing of therapy study in advanced renal cell carcinoma. A brief background on the dementia biomarker study. So androgen deprivation really still remains the backbone of prostate cancer treatment. However, there's been a lot of questions regarding the association between androgen deprivation and neurocognitive decline. Specifically, we know there's androgen receptors in the brain, and that decrease in testosterone level has been associated with amyloid beta development, which is pathologic in Alzheimer's disease, as well as association with other neurocognitive disorders. There has been retrospective studies looking at androgen deprivation in prostate cancer and neurocognitive complications. Most of these are retrospective in nature, some of them showing a positive correlation, others not, with meta-analysis being overall inconclusive, likely due to, it's retrospective. A lot of these use ICD-10 codes, which we know have inherent flaws, among other reasons. So clinical trials are currently in progress trying to answer this question of whether using anti-androgen, whether it's ADT or abiraterone, one of the second generation AR therapies, such as enzalutamide, apalutamide, or darolutamide, if these makes a difference on the cognitive decline. Most of the trials are utilizing either neurocognitive testing and or imaging, and much less commonly using CSF analysis. The issue with neurocognitive testing is they're not as objective, and with the other two, they're costly and can be invasive for the patient. So our question is really, can we come up with any reliable predictive prognostic blood-based biomarkers to determine cognitive decline in prostate cancer patients getting a variety of different anti-androgens? And the challenge with blood-based biomarkers, there's multifold challenges, but the most important one is the concentration of any blood, any biomarker within the blood will be much less than the CSF. And the question is, which biomarker should be used and how do we detect these biomarkers? They can also fluctuate with sleep-wake cycle, making it even more difficult to find the kind of maximum concentration within the blood for analysis. And this is a study by the Alzheimer's group in 2016. And they analyzed well over 20,000 literature to come up with a summary of the different assays, as well as blood-based biomarkers. As we can see here in these pie charts, there's a variety of assays for a variety of blood-based biomarkers. Unfortunately, none of these are really truly validated in the clinical setting, making it also even more challenging to utilize these for our patient cohort. However, 4 of these blood-based biomarkers did stand out to us. They have been repeated in literature, and they're, I think, one of the slightly more well-validated blood-based biomarkers. All 4 of them are implicated in one way or another in neuron injury, and so BASE1 is a enzyme that clips APP into amyloid beta. Amyloid beta is implicated in the phosphorylation of tau protein, which causes neurofibrillary tangles, which then causes neuron degeneration, releasing neurofilament light, which is a marker of neuroaxonal injury. So our thought is there any way we can utilize these 4 biomarkers within the serum to detect a difference in cognitive changes for our prostate cancer patients? These are, we are able to detect them with Simoa, which is a ultrasensitive assay per literature review. So the study concept for this one is in 2 parts, part 1 being retrospective and part 2 being prospective. For part 1, the primary objective is really to determine if these 4 potential blood-based biomarkers. Amyloid beta ratio of 42/40, neurofilament light, thou, and or base1. Levels differ among prostate cancer patients who have received no systemic anti-androgen therapy, ADT only, or ADT plus abiraterone, enzalutamide, or apalutamide, kind of a combination blockade. And our primary outcome measure would be the median levels of these potential blood-based biomarkers measured by Simoa assay. To come up with our cohorts, we tapped into our GU biorepository, which is a biorepository of consented GU patients with both clinical data and tissue or blood banked, with the purpose of answering clinical questions. So we looked at all of our prostate cancer patients with banked blood, and we divided these patients into those who had no systemic therapy but high risk prostate cancer, so that their baseline characteristics are more similar to the other group, ADT only and ADT plus an abiraterone or second generation AR therapy. This is for at the time of their blood draw that they were on these specific therapies. We came up with analysis cohort of 20, 20, and 13 based on inclusion and exclusion criteria. And the criteria are mostly, do they have enough clinical data for analysis? Did they actually have blood drawn while they were on the therapy of interest? They have to have no baseline cognitive complications, etc. A descriptive analysis, preliminary of the 3 cohorts are presented here. Overall, they're relatively comparable in terms of their baseline characteristics. Ethnicity was majority white. The age was mid-60s. Education, Gleason score, PSA, and de novo metastatic status were all quite similar among the 3 groups. And then looking at kind of their states at the initiation of therapy. The prostate cancer states obviously different among the 3 groups due to the difference in the reason for starting those particular therapies, but the ECOG comorbidities and baseline laboratory values are relatively comparable as well. So the next steps for this study, we are going to enroll 7 more patients into cohort C to make that a 20-patient cohort as well, after which we'll analyze the basic characteristics as well as the potential blood-based biomarkers mentioned before on their banked blood, with the hypothesis that the levels will increase with increasingly potent antigen blockade, meaning it's higher in the combination blockade cohort C than cohort B of ADT only, than cohort A with no systemic anti-androgen therapy. If a positive signal is seen in part 1, then the project will move on to part 2, which will be a prospective randomized open label pilot trial, where we'll look at ADT versus darolutamide versus enzalutamide as monotherapy in non-metastatic hormone-sensitive prostate cancer patients with biochemical recurrence. Our goal is really to see if there's a cognitive difference between darolutamide versus the other 2, given darolutamide does not cross the blood-brain barrier. We know therapies such as ADT and enzalutamide in clinical trials have had side effects, enza with seizures, both ADT and enzalutamide with cognitive complications. So if darolutamide, which in previous trials show less cognitive complications in seizure risk, if it truly translates into a clinical, less decrease in cognitive function clinically, then that would be very impactful. So we'll be correlating our potential blood-based biomarkers with cognitive function and quality of life in this patient cohort. Moving on to the rapid sequencing therapy study. This is going to be in advanced renal cell carcinoma patients. A brief background, the 5-year overall survival remains quite poor for these patients, with about a quarter of them not receiving any systemic therapy, and of those who do, only a fraction of them eventually receive a second line. And the treatment option for first-line therapy for advanced renal cell carcinoma, In a way, it's a luxury problem, but it is a problem in that there's a variety of first-line treatment options, and the challenge is how to determine the best initial treatment and subsequent therapeutic options for patients. And this often depends on the physician's experience, comfort level, and cross examination of individual clinical data. For example, both Epi-Nivo in checkpoint 2 and 4, there's very good long-term follow-up data in these patients up to 42 months, where quite a few patients were still responding to therapy at 42 months, I believe 38%, versus axitinib pembro, which is a TKI immune checkpoint inhibitor combination. In Keynote 426, these patients have very high efficacy, or these drugs have very high efficacy, but they don't have as good of a long-term follow-up. And the question also arises, if we use the TKI and the immune checkpoint inhibitor up front, then what will be the subsequent therapy for these patients? So we think reliable biomarkers are also needed in this patient population. And the concept of this trial is TKIs such as cabozantinib may promote an immune permissive tumor microenvironment, and there might be synergistic effects between TKIs and immune checkpoint inhibitors. However, there's higher toxicities with concurrent treatment. Earlier studies of Nivo and sunitinib, as well as pembro and petabinib, were actually stopped due to synergistic liver toxicity and severe fatigue. Even in the Keynote or Checkmate 214 study of Nivo and Epi, the combination did show some room for improvement in terms of toxicity, and the discontinuation rate or withhold of therapy rate was relatively high. Discontinuation for either therapy was about 30%, and I think for withholding therapy it was 60% or so. So our thought is a sequential approach of rapidly sequencing cabozantinib to Epi-Nivo with or without lenvatinib everolimus in treatment-naive patients with advanced renal cell carcinoma. And the idea is patients will receive 12 weeks of cabozantinib, followed by 12 weeks of Epi-Nivo, and then if they respond to Epi-Nivo, defined as complete response, partial response, or stable disease, patient will go on to Nivo maintenance, and if not, then they will go on to second-line therapy with lenvatinib and everolimus. Tumor biopsies will be obtained before initiation of therapy, before Epi-Nivo, and then at progression. The third one is optional for patients. And these tumors will be utilized for biomarker analysis within the tumor microenvironment. The primary objective of the trial is preliminary efficacy as defined by objective radiographic response, as well as biomarker analysis as defined by tumor immune genomic profile. And the secondary objectives endpoints include safety, efficacy as defined by other endpoints, and patient-reported outcomes. This trial actually just received funding from Exelixis, so we're currently in the protocol writing process. And that's it. I want to thank Dr. Sao, Dr. O, and the GU team, Dr. Miller and Dr. Kozik, and of course my co-fellows. This is my disheveled dog this morning who thought it was too early to wake up at 8 in the morning. And with that, I will take any questions. Very good.
Thank you, Janie.
Yeah.
I think we might have time for one question if anyone has one. Okay.
Okay.
All right.